Thank you, Jerry. Indeed, I'd like to present to you tonight a personal journey toward my own career in global health. And my global health career, I should say, really began at the age of 12 when I realized very clearly that, in fact, my passion was to pursue a career in diabetes research. Well, why was that, in fact, so clear? I think all of you would understand were you to have read the same story that I read when I was 12. Growing up in Toronto, the very same city where Banting and Best discovered insulin in 1921. Banting, a young country surgeon, woke up in the middle of the night with a rather brilliant idea, which with some difficulty he convinced the physiology department at the local medical school. And pursuing this brilliant idea throughout one long, hot summer with a student named Charles Best, they managed with considerable difficulty to finally extract the elusive insulin extract from the beta cell of the pancreas, and were able to successfully treat their first patient, named Marjorie. Marjorie had been dying in a diabetic coma, was very close to death at the time that the extract was successfully obtained. And as you can see here, Marjorie subsequently became very perky. It wasn't long after that that they were actually able to treat their very first human patient, whose name was Teddy. As you can see here, Teddy was also on the verge of death, completely emaciated, suffering terribly, facing the same fate that was faced at that point by every child with diabetes, a certain death. The only treatment was starvation, which could prolong the lifespan by about a year. Insulin became available, and Teddy was able to have a normal life. As you can see here, he was looking very hale and hearty after beginning his insulin treatment. Hopefully it's not too difficult for me to explain to you why a career in diabetes research seems so appealing. However, at the age of 13, I had a bit of a shift in priorities. I don't know if any of you can relate to being 13. Actually, some of you are a little closer to that than I am, but in any event, at that point in life, it seems that one starts to address the big questions in life. What is the meaning of life? Is there more than this? And so on. For me, there was a sudden thought that I suddenly felt that God was much bigger than something on Sunday mornings. And so with all of the enthusiasm that only a 13-year-old can have, I at that point made the absolute resolution that I was going to save the world by becoming a medical doctor to Africa. And so I considered that with great enthusiasm until it gradually dawned upon me that, at least at that point, the conventional wisdom was that the only way to be useful in a place like Africa was to study infectious diseases. Now, try as I might, and I can say I did try, throughout medical school, I really could not develop much of a passion for these guys, sorry to say. And so, despite much effort to become excited about the idea of chasing worms around Africa, it really didn't happen. And so, instead of that, I did end up pursuing my original passion, which was diabetes research, which brought me to Albert Einstein College of Medicine. And I have had the opportunity here, with the help of very sophisticated research methodology, to be able to pursue fascinating questions in human subjects using this type of methodology, which would be hormone infusion studies. In human subjects, we can address an enormous number of different physiologic questions. We can pursue the various metabolic defects of diabetes. I find this to be absolutely fascinating. But it was with some resignation and sadness as I embarked upon this career, diabetes at that time being considered to be a disease of affluence. I did have quite a bit of feeling of regret that I would never be useful to poor people in the developing world. Now, that all did start to change back in 1996 when friends of mine strongly encouraged me to go with them on a medical mission trip to Romania. I completely refused. I told them very clearly I would be of absolutely no use. I knew nothing about parasites. I thought that that was a done deal. They insisted that that I go with them anyway. I turned out to be by far the busiest member of the team. And in fact, we discovered that every adult that we encountered there had hypertension, and a good number of them also had diabetes. And as a consequence of this, we saw many people in their 40s who had had strokes and myocardial infarctions. Now, we didn't have to look very far to find the culprit in this story, who's right here. Now, it happens that pig fat is the local delicacy. Perhaps you'd understand that a bit better if you were there and you had everything cooked in pig fat. If you went out to work in the fields and you could just take a large slab of pig fat and put it on a piece of bread, and that would be lunch. Be that as it may, despite all of the gastronomic delights of pig fat, you can see that it does have its consequences, and it certainly was good for business at my clinic. Now, in stark contrast to that was what we encountered up in a small town up in the Andes, which I visited back in '97. By direct contrast with what we saw in Romania, we did not diagnose any adults with hypertension or diabetes. In fact, the lifestyle there was very different. A lot of physical activity, a diet that was high in fruit and vegetables and very low in animal fats. The bottom line was that these early experiences in global health really reawakened in me something of what I'd felt when I was 13, that earnest desire to try to serve those who are so poor in these countries. And interestingly enough, moments of insight come in rather unusual ways. Mine actually happened to come on a coffee mug with this particular quote by Thoreau: "Go confidently in the direction of your dreams." And honestly, as I contemplated that, it became clear to me that my dream really did lie in the realm of trying to make what I was doing more useful to the most poor and vulnerable. Interestingly enough, in 2001, I learned a very interesting fact, and that was that diabetes was in fact becoming a global epidemic, and that about 90% of new cases of diabetes in the world were occurring in the developing world. That was an incredible paradigm shift for me. Now, as you can see here, we're looking between the years of 2000 and 2030, looking at incredible rates of increase in diabetes in so many parts of the world. No surprise, of course, that this is happening in North America. Look at what's happening elsewhere in the world, and in fact, we're looking at enormous prevalence and increases in India and Southeast Asia and China. So this is the real story of diabetes in the world as we speak, with a projected prevalence of over 366 million by the year 2030 if current trends were to continue. I'd like to now show you a bit more of a human side of this particular story. So what I've been able to see on the ground through these various experiences, this is an elderly woman in Guatemala losing her sight, losing her renal function, a lot of leg pain, thoroughly disabled by diabetes. Why, in the midst of the poverty of rural Guatemala, is this a problem? Intriguingly enough, very high carbohydrate diet. As I was learning to take proper dietary histories on patients in Guatemala, I kept hearing the word tortilla frequently. Now, I kept assuming that that meant it was in the singular. I soon learned that that meant five. So there's more informed members of the audience. So basically, I quickly learned that that meant 5 tortillas with every meal, on top of the white rice, on top of the sweet beverages, on top of the white potatoes, et cetera, et cetera. Now we're underneath a bridge in Bangkok. We're in a community of people who happen to not be able to afford housing. They're living in packing crates under this bridge, but this community is settled enough that they actually have their own store. This lovely woman living in this community does not have enough money for decent housing, and yet can afford to become obese thanks to the very, very cheap prices of what we would consider to be bad foods. Besides these on-the-ground personal experiences, I've had a chance, as Jerry was mentioning, to be very involved in continuing medical education meetings, which alternate every year between Kenya and Thailand, serving both Western doctors and national doctors that represent altogether over 70 countries. And this has been incredible for me because that has magnified my own exposure to what is going on in so many parts of the world. Interestingly, as I was attending more of these meetings, I kept hearing a very similar story from doctors serving in India and in Africa. They kept saying to me, we're seeing a lot of very lean, poor, rural people presenting with a very difficult to treat form of diabetes. They're very insulin resistant when we give them insulin, and it's difficult to manage them. I, coming from North America, of course, knew everything, so I immediately told them, I know you think that they're lean, but in fact, what's really the case is that any fat that they have is actually just deposited in their abdomen. You're not seeing it, but that's actually what's causing the problem. Finally, it took one of them to say to me, I'm a surgeon. I've operated on a lot of these patients. They don't have any fat in their abdomen. So that was the wake-up call for me to think, maybe we really were dealing with a whole different phenomenon of diabetes presenting in the developing world. And so in trying to seek more information about this, I've been looking through the literature, and in fact, there really is not very much. But there has, in fact, been an entity described since 1955 called various things, but one of its names is malnutrition diabetes. And what is, in fact, known about it, these patients have malnutrition. They appear to have had lifelong malnutrition. They present very lean, protein deficient, underweight. It tends often to be associated with serious infections, often tuberculosis, often stressful events. I've met a number of these young people, especially children in the hospital in Uganda, where they've often had the loss of one or both parents, and then they present with severe diabetes. Young age of onset, high insulin requirements, and for those that haven't yet studied this in biochemistry, what differs between these patients and ones with type 1 diabetes is that they do not develop ketosis. They don't go into ketoacidosis. They can survive without insulin, but they have very high blood sugars and can be very ill nonetheless. And reported in India and sub-Saharan Africa. Well, what does this really look like, again, on a more human level? I'd like to show you 3 faces that I've encountered. The first is a 15-year-old boy that we diagnosed in 2005 in rural Uganda. He'd had a 3-year history of wasting away, losing a lot of weight, and being very dehydrated after his father died, and his widowed mother could not afford the 20-minute ride to the local hospital, so he didn't get medical care. Now, we were thankfully able to get him to the main medical school. He was able to get care, and with kind foreign friends, he received a lot of test supplies, a lot of insulin, some follow-up, much, much more than most patients will ever receive in Africa. Despite that, died about 3 months later, probably from a low blood sugar. This is a 27-year-old woman who I met in May in Uganda, at that point dying from renal failure, a single mother. She's died since then. The time that I met her, she was experiencing severe chest pain. They couldn't get an EKG, they didn't have one available. The medications had run out. We were somehow able to get a hold of some antacids because we had a suspicion that this was actually excess acid related to the renal failure. And actually she did get some temporary relief, but when they ran out, she attempted to get relief by pounding her fists on her mattress to try to counteract the pain. Again, she has since died of renal failure. The third is a 15-year-old orphan named Isaac, who is also in Uganda. He is attempting to care for his elderly grandmother, and so in order to do so, he sells the insulin that he gets for free at the local clinic. We met him because he came into hospital very ill, very high blood sugars, and we're now working with various organizations to attempt to make sure that his outcome will be better than others that we've met. Mahatma Gandhi once said, "Remember the face of the poorest and the most vulnerable person who you have ever met. And as you contemplate your next step, think to yourself, how is this going to help this person. And so for us, the next step was to found the Global Diabetes Initiative with the goal of attempting to combat the global diabetes epidemic by harnessing Einstein's strengths in research and education and by building strategic partnerships. And what does that mean in terms of the partnerships? Thank you. Okay, so now that you can see what we're all about, we can actually move on. And so partnerships, then, I'm going to point out we have a number of partnerships within North America, which has been very helpful with other partners that have been involved long-term in work related to diabetes in the developing world. But I'd like to highlight a triangular relationship that we're developing on the basis that it is not our desire to be introducing North American medicine into the developing world. Rather, we feel that we're in a position of needing to learn from people who have already been very successful at managing diabetes in a developing world setting. That has led us to the superlative medical school, CMC Vellore, in southern India. And the triangular part of the relationship also involves a partnership that we've been developing for a number of years with the leading medical school in Uganda, Makerere University, based in Kampala. And so then attempting through this partnership to really build upon all of our strengths in order to try to address some of these problems in the developing world. So first of all, going to southern India. This incredible place, one of the premier medical schools in India, started by an American woman, 1900, has grown to an incredible facility, 3,000 inpatient beds, 5,000 outpatients a day, incredible facilities, people coming from all over to get the best level of care, but also incredible commitment to the poor and being able to deliver the highest level of care to the most vulnerable populations. What was of great interest to us was that the research sophistication that they have at CMC Vellore. You'll see these pictures don't look all that different from what I showed you at Einstein. They have the same type of hormone infusion studies that we do. They're able to do sophisticated measures of triglyceride content of different tissues. They're able to measure energy expenditure by various fancy means. And the bottom line is, put these two things together, population with malnutrition diabetes, which we never see in the West, partnered together with sophistication and research that would rival what we have here, and very willing and expert partners. This is then allowing us to start to address questions about this elusive disease, malnutrition diabetes, afflicting millions of people in the world in 2009, and yet about which so little is known or understood. So this really is offering us some incredible opportunities. In addition to their research expertise, CMC Vellore has developed quite an astounding medical education program for diabetes. They have now educated 100 hospitals around India in a very comprehensive approach to diabetes management. We're actually partnering with them to move this program beyond India. And in order to develop that in multiple different places, what I'm going to do is show you an example of how, in fact, this is taking place. And so I wanted to share with you a couple of pictures of a meeting that we just held in August in Uganda, held at a beautiful agricultural research center right outside of Kampala, attended by about 100 doctors and nurses who came from 22 different medical clinics around Uganda, one of them being patients from Kasoro, one of Dr. Passione's finest. And so these doctors and nurses convened in a beautiful setting, and they were a great audience. There were also a lot of teachers who were the faculty from Makerere University in Uganda, as well as Elizabeth Walker from Einstein and myself and others from other institutions. And basically we treated them, or we tried to bring together a comprehensive array of lectures in different topics, a lot of it related to behavior and lifestyle. We found them to be just an incredible audience. From early in the morning until late at night, they were giving their most rapt attention. It was actually very hard for me to imagine doing so and sitting on those little plastic seats all day long. But they addressed the whole thing with great fortitude and great passion for learning. We also had an opportunity to hear from them about their experiences of managing diabetes in all different settings around Uganda, to learn from their wisdom, to learn really from their triumphs. And that was an extremely exciting experience for us, culminated in a graduation ceremony, which was extremely moving for all of us that took part in this. And what I'd like to do is to say that while a lot of this has been faculty that have been involved in this up until now, and you can see certainly that what I've been showing you has been related to research and to education, but as I speak to so many of you, and as I become excited by your enthusiasm and energy, and as people come forward expressing an interest in being involved in diabetes in these different projects, I'd like to say that we are absolutely developing ways in which students can get involved in meaningful ways. And so if any of you would wish to speak further about that, please do contact me, and I would be delighted to speak with you further. What I'd like to do is just to distill my own personal experiences into 3 little points to pass along to you at this point. First of all, above all, follow your passion. Do not by any means think that in order to pursue global health, you're going to have to do so in a particular way. I think it would be much more important to say to you, what are you passionate about? I can be certain, almost certain, that just about any specialty where you pursue your own personal passion, you will be of great use in the developing world. Secondly, despite everything that happens in your rigorous medical training, medical school and postgraduate, please do retain your humanity. Please keep in perspective what Gandhi has taught us. And finally, I really want to encourage you all to go confidently in the direction of your dreams. And I would also very much like to thank all of the tremendous institutional support that has been behind all of this. Thank you so much.